Hi, we're going to be going over Chapter 15, Part 2, in The Patient as an Individual. We started talking a little bit in the last section about the religious and spiritual beliefs that influence many healthcare practices. We talked about the faith healers and certain different tribes or groups who have shaman or holy people. Some people truly believe that illness is a will of God or a punishment for something we've done. Prayer is used over so much of the world. The prayers may be different, but it is considered prayer. And they had a study not too long ago that they said around 80% of people actually use prayer when their health is suffering. We talked also about the increase of interest in the mind-body-spirit movement in the United States. This is the basic belief of many, many cultures. The yin and yang, we looked at the Native Americans, we've looked at people across the world, and we take those basic beliefs and bring them into the realization that the mind, body, and spirit are connected. And we're finally accepting that in the United States. Some of the other things that we've talked about were the body humor therapy. With the Hispanic culture, they use those 4 fluids to control the body. This is going to be on page 325, and they are going to be hot and wet, hot and dry, cold and wet, and cold and dry. So the illness comes when those are out of balance. And so what they do is they treat the condition to get the balance back in the body. And the box on page 325, box 15-2, will give you some of those conditions that are there and some of the remedies that you'll see as well. So, true or false, Tai Chi is a form of acupuncture that originated in China and is becoming accepted in the United States. That answer is false. Tai Chi is actually a form of Chinese martial arts. It involves meditation and breathing as the center of most activities in mind-body medicine. And you go inside yourself, center yourself, and then you perform very slow body movements in a ritualistic type manner with Tai Chi. Herbs and plants. We have been using herbs and medicinal plants for thousands of years. Many are still used today. There's a big influx of people in the United States using herbal medicines or natural remedies. The thing that we have to remember with this is they are not controlled by the Food and Drug Administration or the FDA. And with that, there is no type of quality control with your herbal medications. So if you go into the drugstore, or you go into the grocery store, and you look at the shelves, not right now because there's nothing on them, but you go in and look in the shelves and you'll see 15 different brands of these different herbal supplements. You really need to research them. If it's got one little sprinkle of that herb in the bottle, then they can call it that herb. There are many companies that are very, very reputable, and you can research that on the internet. Usually they will be a little bit more money, but you're paying for a little bit better quality product. The one thing that we have to remember is just like prescription medications, herbs can interact with prescription meds. So we need to make sure that patients are telling us what they're taking, and we need to be able to document that so the physician or provider is aware, so they know and they can research if there's any type of negative interaction with those. You can actually go just Google herb and drug interactions, and you'll get this handy dandy little site that you just type the name of the herb, you type the name of the medication, and it will tell you if there's any type of negative interaction with that. So we're going to move on to human needs. And many of you may have already studied this in psychology, but we're going to go back over it and talk about it a little bit. They felt that considering the needs of people is a really useful approach to understanding human behavior. And truly it is. I don't know if you've ever just sat and watched people in a mall or a park. I love doing that because I love to see how people are different and the different things they do. But they were trying to find a way to be able to look at the needs and find out what we need at different levels to be able to advance. So Maslow, who is the one that we will be talking about, it's Abraham Maslow, developed something called Maslow's hierarchy of needs. Now, Mr. or Doctor, I guess I don't know what he is, Maslow felt that after he developed these levels, he truly felt that you could not move from one level to another until they met the needs of that one level. So we'll show you in a second what that's going to look like. There's been a lot of controversy with that right now. There has been a lot of talk about people have different needs. Cultures have different needs. So where some of us, we say that we need shelter and we need other things until we can get up to self-actualization or love and belonging. They are finding now that indeed is not the truth. Everybody is an individual, and because of that, we all come with different things. And so for some people, monetary things or possessions aren't going to be important. It's going to be people and relationships. And so there's just a lot of people coming to the forefront and saying they need more studies around this, because Maslow developed this by using strictly high-achieving males, and he just observed them and he made that list, or the ranks from them. And they were high-achieving white males. I don't think I said white before, right? So in some cultures, we may not have the same basic needs. They may be very different. And if we have a different socioeconomic background, maybe our needs may be different. So there's a lot of different controversy right now. And what's really coming out, while Maslow says we can't move from one level to the next, people are saying now we have to look at these and realize that everything may not be met, and you can indeed move on without it. And we'll look at those as we go. So here is Maslow's hierarchy of need. I just found this, and I think this is hysterical. As we have, this is the biggest need that we have, and we have toilet paper down here at the bottom. Now, when somebody watches this in 10 years or whatever, they are not going to be able to understand why this is funny. But as we are living through this pandemic and have no toilet paper, we all understand that. So we'll go on to the real Maslow's and talk a little bit about each level. So the bottom level, or the base of the triangle, is physiological needs. And these are going to be things like air, water, food, shelter, sleep. Our second level are safety needs. And this is going to be personal security, employment, resources, health, those type of things. The third level is love and belonging. That's friendship, intimacy, family, sense of being connected. Our fourth level is esteem. And this is when we are respected. We have status within the community. We're recognized. We feel pretty good about ourselves. We have good self-esteem. And then that fifth and the top of the pyramid is self-actualization. And he describes this as the desire to become the most that one can be. So let's talk about these more in depth as we go. So level 1 is physiologic needs. So we're going to look at that and we're going to consider, what do we need? And again, this could be air, shelter, sleep, water. But this is interesting when you look at it, because yes, we need air and water. We have to, food, in order to live. We all need that. We know that. But is shelter really that important? What happens if you're homeless? What happens if you're in prison? That doesn't mean you can't do something amazing. Actually, in one part of the text, I can't remember where it is, it talks about one gentleman who wrote Don Quixote, and he was imprisoned. And so does not having shelter affect us as much as Maslow thought? For some people, yes. For some people, maybe that's no. In some cultures, maybe that's no. Safety and security is the second level. And this is important to think about, because this is when you're free from physical and psychological harm. So think of someone who is in an abusive situation where they don't feel like they're ever safe. And remember, there doesn't have to be a mark on that person. The abuse can be totally psychological. So they are never going to be able to get into those upper levels, because they have such fear that it's going to be very difficult for them to develop relationships and feel good about themselves, because that abuser is telling them they're horrible, nobody's ever going to love them. So it is really, they're really in a level that they really are kind of stuck in because of the situation. Again, employment and health, we can think about this right now. We have a lot of people who have lost their jobs. They've either been laid off or they've been furloughed because of this pandemic. And so all of a sudden we were sitting pretty good up there at level 4, feeling pretty good about ourselves. And then all of a sudden, bam, the rug was taken out from underneath us and we no longer have money. And how are we going to pay our bills? How are we going to make ends meet? How am I going to be able to afford food? It's really it's devastating for that person. The other thing is health, and be diagnosed with COVID-19. You don't want to. This coronavirus is really nasty, and it's not being selective. I know they keep saying older adults who have pre-existing conditions, but when you look at the list of people dying, they're all over the place. There's healthy people all the way through. And so it's scary. It's absolutely scary. So we were in a pretty good place, and having to shelter in place, it has really made people fearful. And it has definitely changed what our needs are because of this situation. Level 3 is love and affection. This is where we're going to have friendships and intimacy, family, a sense of belonging or connectedness. Now, this does not mean you have to have sex. This means that you just can have a good relationship with people and have, feel connected to them. Think about priests who are not supposed to have sex, our nuns in the Catholic Church. While they don't have sex, they still have a sense of belonging. They have definitely friendships and family, because they are a family within themselves when you look at the order that they're in. This is really interesting because when we first moved to Cumberland, it was a big move for us. We were both from the city. We had gone to college in the city, and we came to a very rural area who was very interesting, very nice people. They always treated us very well, but we just never felt like we belonged. It took us a while. We were called carpetbaggers because we weren't born here and we just moved here. But what we found after a year or so is we got to know people at the college and at church and different activities around the community. And then we started to feel that sense of belonging. And it made a huge difference. We weren't sure that first year if this was a good move for us. But after we've melded in and got to know people and really felt like we were part of the community, we knew we were in the right place. Self-esteem is level 4. And this is when we have a good feeling. I mean, we have a good opinion of ourselves. We're confident in who we are. We have respect of others. We have status within our group. And we're recognized. It doesn't matter the age. This can be, teenage kids. This can be 90-year-old people. This can be, middle-aged people, people in their 20s. So as long as you are feeling comfortable with who you are, you have the respect of your peers and recognition within that group, you are there at that self-esteem level. The last level is self-actualization. And self-actualization is actually, the book calls it the desire to be the most you can be. And the achievement of your full personal potential. I like that because I like to think of this as setting a goal. Okay, we set goals for ourselves all the time. And I always think of students who are in the programs when I think about self-actualization. Because you guys you've come to the college, you're working like a dog through these classes, is all you guys want to do is graduate. And so when you walk across that stage and you have that diploma in your hand, you are at that self-actualization. You have reached that goal. You have reached where you want to be, and you are happy as a clam. Now, the one thing about self-actualization, it doesn't last real long because we're human. And once we meet one goal, we're not just going to sit there and stay there for a long time. We are going to start setting other goals. So now you're going to start thinking, okay, now that I've graduated, maybe I need to get a job. Maybe I need to go on to further my education. So there's always goals that are set. And now we slip back down into that self-esteem area and we can go and try to meet our next goal. When we talk about illness and injuries, this absolutely alters what we need or our human needs. In order to fully recover, our patients are going to have to move up that hierarchy. So we were talking before about this pandemic. So we're sitting pretty, let's say we're sitting pretty up here at self-esteem, and wham, underneath us, we start getting sick, we're diagnosed with COVID-19, and we lose our job. We are going to fall down that pyramid, and we are going to probably be sitting very heavily on the first level. We're just praying we're going to live because we don't know. This is such an unknown. And so they have decreased in that. So as people recover and we need to work with them, we have to help them move from stage to stage. What we need to do as health professionals is we need to be able to recognize the patient needs at each level, and they are different, and be able to help the patient meet their need at that level. And that's really important. We have to help them. We're not going to meet it for them. They have to be able to meet that need. So before we move on to defense mechanisms, there's a really good example in your book. And it talks about a gentleman named Carlos. And this was on page, let me look here, 328. Carlos is a 29-year-old man. He's a welder. He's married. He has 2 children. His wife stays home with the kids. She's a homemaker. And lo and behold, he's out on a Saturday afternoon. It's beautiful. And he has a motorcycle accident. And they find when he gets to the emergency room, he has a spinal cord injury and is now a paraplegic, which means that he's going to be paralyzed from the waist down. So much has changed in the matter of a split second. He was free and carefree, family, working, doing all these wonderful things, and now he's in the hospital. He can't walk. He's going to be counting on the staff there to help him with every single thing that he's going to do, including having to go to the bathroom. And so this man has gone very quickly from somebody who was very self-assured and taken down very, very quickly. And I have to tell you, from an experience of having to be taken care of, I'm a control person. And so having somebody take care of me is really difficult because I want to be able to do it myself. And so when I can't, I get a little bit snappy. You can ask my husband. He would agree with me 120%. So Carlos really significantly changed after this accident. So his survival really depends on those physiologic needs. Is he going to get air? Can he breathe? Is he getting water, food, those type of things? Well, those are pretty much met after we stabilize him. And we have the shelter for him because he's in a hospital. But then what happens is we're going to have to move to that other levels. Now, when we look at safety and security, the things that we can do to make him feel more safe and comfortable when we're working with him is make sure we introduce ourselves and we know the patient. Let him know if you need anything, this is how you're going to contact us because we're going to be here when you need us. He needs to learn to be able that he can trust people. Okay. What their routine care is going to be. What can they expect every single day? Remember, they have lost control of almost everything in their life. And so having a little bit of control and knowing what's going to happen when is very important to our patients. So when that safety and security piece, this is when Carlos is going to be saying, oh my God, what am I going to do? I am never going to be able to afford, the hospital bill. I don't know what we're going to do. How am I going to feed my family? The one thing that we don't ever want to do to our patients is trivialize what their thoughts are. We do not want to say, don't worry about that, everything's going to be okay, because that doesn't help our patient. We need to be able to support them and say, let's take one day at a time, get the family in there, get them supportive with them as well. It's really important that they start to feel much more safe and secure. Well, then Carlos is going to go up to the love and affection. And this is really difficult for people who have accidents because now they're broken or they're damaged goods. They feel like they are. And they don't know. Here he was out riding his motorcycle with all of his friends. Are those friends who now are still able to get up and walk away and do everything that they want to do? He's going to be stuck in a wheelchair. Are they still going to be his friends? Is his wife still going to love him? Is he going to be able to have sex with his wife? All of these things this man is thinking about because he doesn't know. He has no idea what's going to happen for him. they can get extremely fearful and frustrated. And I get it. I really do understand this. And so they may get a little crabby. But what we need to do is we need to deal with them in a very compassionate way. Even if they're snarky and snotty to us, we still treat them with respect. We treat them with care, and nothing that they're going to be able to do is going to turn us away. That's what they're testing. Are we going to be there if he acts horrible? And again, slight touch if it's appropriate. Let him know, that you're there. If there's anything that you can do, listen to him. Sometimes when you have somebody to talk to, it's much easier to process. So if that person wants to talk to you, just sit and listen. You don't have to fix it. You just need to listen. And we really need to encourage those family and friends to participate and come in and visit and make them feel wanted and loved. The esteem needs, again, we go from there. Carlos before this always defined himself in terms of his role. He was a dad, he was a husband, he worked, but now he has to find out, he valued what he had rather than who he was. And so, yes, he valued what he was rather than who he was. And he worries about these type of things as we go. Again, financial security, working with the patients and saying, you're worth my time. You are, your disability doesn't detract from your value as a person. This is really, really important to them, because they need to recognize that just because this has happened, it doesn't make them any less of a person. Their value is still the same with the people that love them. Again, the things we can do is, again, listen. That's one of the biggest things. Show interest in what they're saying. Be able to ask them what they would like. So we have the opportunity between 9 and 12 to do your physical therapy or your bath, or what order would you like it in? That gives them back a little bit of control, and it makes them feel a little bit better. Believe me, it doesn't take much just to have one thing that you can control is so very important. Again, treating them with the respect and dignity that they need, that they deserve. We always ask before we do something. We just don't go in and assume it's okay. We'll say, is it okay if I do this right now? And if they say, no, I'm not really feeling it right now, then we come back later. Okay, so we need to think about that. And then self-actualization, that gets to the part where they're going to have to probably find work, different work that is going to make them feel more meaningful and connected to who they are and what they are. They're going to be able to make time for things that they've always wanted to do. So, he didn't ever go to one of the kids' classroom plays. Make time to do that, because what he's found is life's is not a given. It could be gone within the blink of an eye. So really start to look and think about what's important. When you look at people like that, and your book talks about two people, and one of them was Christopher Reeves, and one was Michael J. Fox. And these two men, and I've seen a lot more. I've seen soldiers that come back with both legs gone and an arm gone, and they are the most amazing people. I don't know how their spirit has gotten them through. I have such high regard for them, because I don't know how I would be. I know I'd be pouty for a while, but I just admire them so much. But Christopher Reeves was in that horseback riding accident, and he was paralyzed from the neck down. It didn't stop him. He did so much. He and his wife both actually went and advocated for spinal cord treatment injuries. They went to Congress. They did all kinds of fundraising. They did so much and spotlighted it because of what happened to him. The same thing with Michael J. Fox. He was diagnosed very early, 20s or 30s, I believe, with early onset Parkinson's. He didn't just disappear. He has been very much an advocate for trying to find treatments for Parkinson's and research for Parkinson's. So this is the thing that people can do. They can either choose to lay down and just be depressed, or they can find a way that they can make really a huge impact in the world. Okay. Defense mechanisms. These are responses to perceived threats to our self-esteem. We do these all the time, you guys. Anytime we are anxious or discomfort, have some discomfort, we sometimes use these defense mechanisms to make it better. We use them generally in times of stress. So if we're sick, if we're injured, but sometimes we just use them because we can. There is a great chart or table on page 331 on the examples of common defense mechanisms. This is a hint, hint, hint. This would be a really, really good matching type question for a test. Okay? So they talk a little bit about the different kinds of defense mechanisms. And compensation is the first one they talk about. This is attempting to meet a need by substituting something that doesn't actually satisfy your need. So the example they give is recently divorced woman overeats to deal with her loneliness. You know? So what are we all doing? As we sit at home and we're bored, we're all eating. You know, there's so many memes about people whirling out of their house after this is over. But it's compensation. We try to substitute what's going on instead of dealing with the issue at hand. Control, trying to exert excessive control over others when we lose control somewhere else. This is really, I have to own this one. This is their example that they give. A hospitalized patient insists on being given an exact time for their schedule of care. I want my bath at this time. I want my dinner at this time. It's the only thing that they can control. And so sometimes that can happen. So again, defense mechanism. Denial. Just downright denying it, pretending that something isn't true. There's this kind of a lame example, but they say a business executive refuses to acknowledge that they have a positive HIV test. We just, some people just choose to ignore as well. Displacement is when we transfer the feelings about one person to another person. I do this so good. So let's say you had a really crappy day and you have to be nice to every single one of your patients. And you walk in the house and your kids run up to you and say, "What's for dinner?" And you go off. You are actually displacing the anger that you were carrying all day to your kids. This is so easy to do. And my husband really does a good job with this, because instead of yelling at me like, a lot of people would do, he will say, "You must have really had a bad day. Do you want to talk about it?" Instead of yelling and getting defensive back, just acknowledging that somebody seems out of sorts and saying, "Do you want to talk about it?" really helps in that situation. They have a couple in the book that aren't on here. It's malingering. Acting out is when expressing you have something happen and you react with an extreme behavior. So their example is the husband kicks the wall when he's angry over his wife's criticism of him. So we see that, I'm a door slammer and a banger. So if you can, you're just replacing that person and you're punching the wall, or you're kicking the door, or you're doing whatever. Malingering is pretending to be ill. I love this one. Students fake symptoms to avoid taking a test at school. Let me tell you, it's just easier to take the test because my makeup tests are horrible. Projection is failing to see your own weaknesses or problems when you see everybody else's. So this is an overweight mom criticizing her overweight daughter's poor eating habits. Not something that you probably want to do. Okay? Rationalization. Explain the behavior with socially acceptable reason. So this graduate nurse says that she's not going to take her licensing exam because she's just way too busy, when the fact is she's really afraid she's going to fail it. But she can rationalize that she's just too busy and she can't do it. Regression, this is when we actually go back in time, and we're behaving in a way that's more appropriate for somebody that's younger. A 10-year-old boy returning to some sucking. Didn't say that right. I know when Kristen just had Caleb, the doctor was saying, don't push him to potty train because as soon as that baby's born, he's going to go right back into diapers. He's going to regress. And indeed, they were right. Repression is keeping unpleasant memories out of our awareness. This is when their example is a young woman lacking conscious memory of being sexually assaulted as a child. This happens a lot, especially with traumatic events. It'll be years before something triggers them to remember the event. And then there's withdrawal, and that's just refusing to communicate or participate in anything. And the example here is the teenage boy refusing to take calls because he's been diagnosed with leukemia. So again, those are important to know. You will be tested on those, probably not only in a multiple choice format, but also a matching format. Question. If the healthcare provider suspects a patient is displaying a defense mechanism to deal with fear, it's best to show interest in the patient's well-being, tell the patient not to worry, ignoring the patient's behavior. So, what would the answer be? We're going to show interest in the patient's well-being. Hopefully you picked that. We need to demonstrate acceptance of where they are and what they're feeling. We need to listen to them. If there's something we can do for them, we will, but we just need to be there for them. Dealing with loss, we will be talking about Elizabeth Kubler-Ross stages of death when we get to chapter 8. But this is something that's really important because it affects people. And I saw this especially with my dad. So when we talk about loss, it can be anything. It can be anything. And it has such a significant effect on a patient's health and behavior, right? So the things that we can look at are things like the death of a loved one, the loss of independence. This is huge. If you have an older parent or grandparent, try taking their car away from them. It is not an easy task. They will fight you tooth and nail. Or telling them that they need to go to a nursing home because they can't take care of themselves in their home anymore. That is a huge loss to someone. Their health and also their physical ability. And so we're going to see these things. I know that when my dad he was in his 90s, he was 95 when he died, but he got so sad. And I said, Dad, what's up? I really noticed there's something different. And he said, all my friends are dying. I'm losing everybody around me. And it just makes me sad. So it might not even be them that has lived with a loss. It's that they're losing people around them or have lost those things that are important to them. How can we help patients deal with loss? Well, we need to help recognize the significance of that person, but remind them of what's important. My dad did the flowers around the apartment building where he lived, and everybody told him what a wonderful job he did and how well he did. Make sure we listen. Again, listening is the key. Give the patient the opportunity to share their feelings. And we can also help patients explore ways to deal with their loss. Maybe we connect them with somebody else who's going through the same type of loss. Maybe we can find some type of therapy for them, or some type of transportation. So if we're taking a car away, how can they get around? These are the things that we need to think about, that what we can do to intervene. Again, seek support from families and friends. This is really important. They need to be there and supporting them. A lot of people will find comfort in their religion. They might have strayed a little bit when they were younger, but you really see that they come back to that as they're getting older. They need to draw on their self-esteem. We need to recognize them. We need to make sure that they understand how important that they are within this community. We know that they are going to use those defense mechanisms that we talked about, and that's okay. We're going to listen to them, and we're going to go, alrighty, that was certainly displacement or regression or whatever it may be, but that's okay. We're going to work with them, listen, and hopefully help them through that. Again, the patient becoming angry and depressed is very, very common. So we need to find ways to make them feel like they're part of it and they have a community with them. The effectiveness of healthcare professionals dependent on understanding and respecting individual differences. Patients have different perceptions of the healthcare setting. And so when we're dealing with this, we need to be looking or watching our patient and looking and see how they are different. Watch them. Find out who they are and what they are. What triggers them? What makes them smile? So by learning about them and listening to them, we can help that person as they're going through these trends. What we can do is observe their behavior and ways of interacting with others. This tells us a lot. Again, I love watching people. I could sit and people watch for hours because it tells you so much about how people interact with others. Do they make eye contact? How formal are they? If they're extremely formal or they don't like eye contact, we're going to remember that may be something that's important to them. So maybe calling them Mrs. Jones is an important piece to that person. Determine if there are language barriers present. We're going to hopefully know that pretty quickly. We're going to ask the patient about their individual preferences. What would you like? Again, when we give people choices, it makes them feel like they have a little bit of control. And that's extremely important. Again, listening carefully to our patients' responses. And know that some people need more information than others do. So we may explain what we're doing and why we're doing it. And we can do a very brief, oh, this is what I'm going to do. And that's fine for one patient, but another patient may want to understand why, who, why, where, and everything of that. So we have to be able to take the time and explain that to them so they're comfortable. So last question, is it appropriate to ask patients directly about their healthcare beliefs? So can we ask them what they think? We absolutely can. It is absolutely appropriate to ask patients. We should be doing it in an inquiring fashion. Again, if I'm interested in hearing this. If they don't want to share, then that's okay. We don't want to act judgmental in any way, shape, or form, but we are just learning. We're learning and listening more and more about what they want. And that's the end of chapter 15. Thanks.